everyone. My name is Dr. Jodie Dewey, and I want to thank you all for being here. If you're having any issues with audio, please just send us a quick message in the chat. Any questions that you have along the way, we'll hold them till the end. But today I wanted to present my talk on marginalized voices as data and drivers of change. And so currently I'm a research scientist with Chestnut Health Systems in Chicago, and I'm a part of the research division, which is the Lighthouse Institute. We are program evaluators, and I'll kind of do a little bit of an introduction as I start my presentation, because this particular presentation sort of is a culmination of where I've been over this time and the kinds of questions that I have right now, being in the position that I'm in. Okay, so just to kind of start with the background a little bit, I am a PhD level trained qualitative researcher. Most of my work is in transgender healthcare. I started that work in 2008. I've also studied the role of masculinity in the training of police officers in the state of Illinois, which is the state Chicago is in. I also currently work in public health, and so much of the research that I'm doing with that right now centers opioid use, community health workers, and getting resources to those most marginalized in terms of COVID-19 resources, and medication for opioid substance use. So kind of like going back just a bit, I think this would be important, is that when I first started, when I was an undergraduate, even before then, I was employed with various police departments and social service agencies. And so like many of you, I was pulled into the work that I'm doing because I had a real interest in helping people, right? We see there's problems in our communities. We see there's problems in the organizations that we navigate, and we want to do better. We want to help people. And so I worked with boys group homes, kids that were brought in from the system either because they committed crimes or because their parents had committed crimes and they were court ordered, or through Children and Family Services ordered to live in the homes that I supervised. I also worked as a dispatcher with policing, and I was also a probation officer. And it was in those roles that I realized that sometimes the systems that we create don't actually help people, right? We find these contradictions in the systems that we work with. And so because of that, and actually when I was a probation officer, I wanted to work with the researcher. And one of the things that we did was we studied a sex offender program, and we wanted to see if the program that we had developed actually reduced recidivism. And what we found is that those who were in this program were just as likely to recidivate or commit a new crime as those who were not in the program. And I was so excited about this research because I thought this was an opportunity to improve the program that we had. But unfortunately, the director of our organization thought this would make us look bad. And the fairly wealthy community in which we were situated, it would make individuals and community members feel uneasy. And so that research was thrown out. And I thought, wow, I cannot believe that all that information was thrown out. And I thought, what are we doing? And how do we know what we know? Like all these services that we offer, how do we know we're doing the right thing? And so I really had the push to go into research and to go further with my education. So from there, I went for my master's and went for my PhD, and I was a professor of sociology in the criminal justice department for over 17 years. And so I was really loving that because I was doing all this great research and, studying transgender healthcare and studying policing. I was the director of the criminal justice program. I moved our program from the 6th to the 2nd largest program. I even developed a 4-course policing certification for students to get them to think about race and to get them to think about gender and how our perceptions of people frames how we interpret the law, how we apply the law. And so that was really important for me. But for the most part, the research that I created was really for other sociologists, right? It didn't really impact people in these systems because it was so far removed from what they were doing. And so, you publish articles and it's behind a paywall and nobody has access to it. You go to conferences and you're sitting in a room with other sociologists and, you don't really see your work being applied. Sorry. And so a year and a half ago, I left academia because I really wanted to shift. I wanted to take research and I wanted it to be able to apply it to the day-to-day work that I'm doing. And so currently, as a research scientist with Chestnut Health System, what we do is we are program evaluators. And so what that means is, in our country, a law was passed several years ago that basically stated that any government funding that a hospital or a public health service receives, they would need to hire an outside evaluator to make sure that they were implementing their program correctly, that they were analyzing that program correctly, because future funding would depend on that. And so I'm one of those outside evaluators. So I evaluate various other programs that are funded. And so this is a new area for me. And actually, I just started taking a couple classes on program evaluation because unbeknownst to me, despite all my research experience, it also is another burgeoning discipline. And so it is very different than research. And so I was excited because I thought, wow, I can conduct these interviews and I can make a difference in the actual programs. And so one specific program I'm working on right now, which I'll get to in a minute, is about connecting people who are opioid users to methadone and buprenorphine and Vivitrol, to medication-assisted treatment. Okay, so what I'm seeing now, I find myself at this professional crossroads, right? Because I'm seeing this disconnect between theory, practice, and evaluation, right? So, first I'm doing the practice. I want to do better, but I don't have the tools to do it. I go to college and I get all these great tools for conducting research, but then you're sort of stuck in this theoretical conversations. And you know that theory is important, but then you get to program evaluation and all of a sudden there's no time for theory. There's just this disconnect across the board. And so what I thought was, how do I do this? How do I create a more critically minded, theoretically driven program evaluation that centers the community and the people? Because after all, they're the ones that we're providing services to. So the problem with program evaluations is that programs are often limited, right? So they're limited by funding decisions. So there are larger organizations who have the ability to put together grants, and they get funding for specific topics of interest. So in the last couple of years, it's definitely been focused on opioid because of opioid addiction and overdoses and COVID-related topics. And so if things aren't important to people, they don't get funded, right? So right now, specifically, we're looking for funding specific to transgender healthcare, for example, is very difficult because people perceive transgender community as a very small community, and it seems like maybe a waste of money, right? Which that'll be another talk that I point some things out on that. The other thing is that when we, sometimes the people who apply for funding and they get it are not the people who are doing the evaluation or the actual research themselves. And so then you have other people in an organization who are creating theories of change and program models in which that research will be based on. And so also, the other issue is who's involved. And so, in the United States, we have this movement right now, which you're probably way ahead of us here, but diversity, equity, and inclusion, and how do we involve as many stakeholders as possible? But the problem is that there are time and budget constraints. And so do we have access to all the stakeholders? Who are the stakeholders? And according to the CDC, the evidence you gather to support the answers to your evaluation questions should be seen as credible by the primary users of the evaluation. But the primary users are not often the service recipients. The primary users are often the healthcare workers, often the people who work within these organizations, right? So the stakeholders who are often the least likely to be at the table, the stakeholders who are those who are silenced or barred from being a part of these organizations for various reasons, are rarely at the table. And at best, sometimes the more valued or legitimate community members are the ones who are speaking on behalf of those who are most marginalized. So I find there's a lot of limitation with program evaluation that I want to be able to address in the work that I do. According to the Center for Disease Control, so the idea of program evaluations is to render judgments, to facilitate improvements in program program development, and knowledge generation, right? Transferability, right? So the problem is that if program evaluations do not value qualitative research and develop a framework for including the voice who use these programs, then the logic that continues to drive programs are institutionally created and institutionally formed practice, right? And so what happens is that we have this sort of a cyclical system in which some evidence is implemented because it already makes sense. And what makes sense is then studied to add to the evidence, perpetually reproducing itself. And so while there might be sort of innovators within this system, right, there's always sort of those workers who want to, push the boundaries to sort of slowly chip away at the process that exists. The framework is not going to implode, right? The system is not going to dismantle itself. It's going to keep perpetuating itself. And so program evaluation, because of these limitations, it's just going to continue to produce the same sort of information. So it neither prioritizes a process of data collection that includes individual voices, and those most marginalized especially, nor relies on them to reshape the practices. And also what gets constituted as evidence, right? When you are on a time and a financial budget, what often gets prioritized is quantitative research. And this stands in for evidence. And qualitative research sort of gets pushed off to the side, right? That, well, do you have a nice story to go with the data? But it never stands on its own as data. And so I think it's important because as a qualitative researcher, and especially as somebody who wants to improve systems, we have to involve the voices of those who are forced or who choose to navigate these systems. Okay. So I wanted to use an example from one of my own projects that I'm working on right now to sort of give an example of why this is so important, right? Why do we sort of have to think about the way we do research, the way we do program evaluations to ensure that we are meeting the needs of the people that we believe that we're helping. So as I said, I'm an evaluator for Chestnut Health System. And one of the projects that I'm working on is connecting people to methadone treatment. And so this is a much larger project. So in Chicago, we have what are called syringe sites or needle exchange programs. And so these are supported by University of Illinois Chicago Health. And there is one site on the west side of Chicago, which is predominantly African-American. And then there's another site that is in a predominantly Latino community. So rather than having to choose to go to a doctor and access methadone or buprenorphine, we wanted to reduce the challenges in doing that. And so individuals can come to the syringe site. It's already a space where we give free needles, we give naloxone. It's very harm reduction based and supportive of the people who live in that community. But they come in and we do an interview with them and we get them connected to help. And so they're randomized into one of two groups. So in the one group, we do what we normally would do. We give them phone numbers to doctors and to facilities that they can get methadone or Suboxone, okay? But with the other group, right, the research side of the group, we have a telehealth doctor's appointment right there in that moment. And then we either order them a car or we get them bus passes and we take them to a methadone clinic to begin dosing, or we bring them to a pharmacy to get their Suboxone prescription. And so we call them back in 3 months and we interview them. And so my part of the project is to do a qualitative interview with them, just to learn as much as I can about their experiences. So some of the things, I need to move this. Some of the things that I found out, which I think are important for us to understand why, I could just look up. First is what I found from the people that I interviewed is that they do adopt a treatment logic that is seen in the programs, right? So like in methadone programs and treatment programs, that abstinence is sort of the main goal, right? So despite the fact that a lot of people, want to mend relationships, they want to get a job, they want to get their own housing, the main goal and the way they understand recovery is abstinence. Abstinence is a part of that goal. What's also interesting is that I hear people say it's sort of this process, right? That one needs to admit that they have a problem, right? So it's a very confessional kind of a thing. In order to start this recovery process, you have to at least admit you have a problem. Individuals also tell me that they have to actively choose not to use, and that they have to ensure that the desire to use goes away, right? So it's interesting when you talk to participants, the way that they sort of break down this recovery process. And I'll get to this point also in a minute also, but one of the participants said that the first step is that you want to be clean and sober, right? And we know this is also outdated language, but it certainly comes from some of the previous programming, sort of stigmatizing language. But the first step is that you want to be clean and sober, right? So that there's this internal desire, right? What we also see participants do is, because the program itself is set up, and oftentimes a lot of medical programs are set up as sort of compliance or not compliance, is that participants begin to see that if they go back to using and they're seen as unsuccessful, how do they deal with that kind of stigma of not trying hard enough, right? And so they develop this identity outside of this, right? Being an addict versus actively using. Right. And so they've adopted the idea that, well, I may always be an addict, but I can choose to not use in this moment. Right. And so they create space of how they understand recovery that expands that understanding a bit, so that they can have a bit of hope, right? That it's not all or nothing, like you're successful or you're not. What I also noticed from the conversations that I have with people is that there's this intense need to humanize themselves, right? To fight stigmatization because of all the experiences they've had in accessing any kind of care, right? So for a lot of these individuals also, they're not just looking into methadone programs, right? They're also dealing with other healthcare workers and social service agencies and childcare agencies. And so, constantly having to defend yourself, to fight the stereotypes and to humanize themselves becomes really important. So what are some of the barriers that they have with formal treatment? So what people are telling me is that they're attempting to manage their recovery within the hassle of these programs. So first of all, just before I get to the methadone program, the Suboxone, it's a little bit easier in a sense, because you see a doctor once and then you get your prescription and you go to the pharmacy and you take it home and you get a 30-day prescription. So a lot of these hassles don't exist for buprenorphine or Suboxone, but for those individuals who did take that, there was just some confusion on what are the next steps, right? So they were a little confused by what they do next once the prescription runs out. But for those on methadone, there's a lot of hassle involved in dosing. So in the city of Chicago, there's only so many dosing sites. The city of Chicago is very segregated, and there are a lot of gangs that have ownership over certain spaces. And so especially those who are using and those who perhaps live and exist on the streets, it's very challenging to get around the city on public transportation. It can be unsafe. They can be victimized. And so going to some of these sites is a real challenge. Not to mention that dosing hours are limited, right? Sometimes dosing sites are like from 7 to 9 in the morning. The idea is people will do it before they go to work, but not everybody works, not everybody can get there at that time. And so lots of our participants would miss appointments. And I'm not sure how it is here, but in the States, if you miss more than 3 days, you can be completely dropped from a program and then have to start the whole process over. Other issues include that the program provides very low doses. And so individuals find that, they don't get their sick off, which means they don't get their sick addressed. They're continually going through withdrawal. So sometimes it doesn't help them anyway. Life of an addict, right? You never know where you are. You never know where you need to be. You never know, what sort of challenges you're going to hit that day, because your life is very erratic. And so having to be a part of a formal program can be challenging. Also, mistreatment by staff, as well as some of the treatment programs are very discipline focused, right? And so if you're late, they don't let you in. They can withhold dosages as a form of punishment. Also, just the basic challenges of navigating healthcare services, right? I remember one guy that I had in my office that I was interviewing, and he needed a dentist. And so I started making some phone calls for him. And he was visibly frustrated because after being bounced from office to office on the phone, he said, you know, just forget it. This is the way they treat us. Now you know what it's like. And so what I thought is just a typical sort of way of getting through different services, he found as a form of disrespect, you know, that being bounced around. And so that can be very frustrating for people. The other problem, which we don't often think about, right, is that some people don't want to be a part of these programs because they expect other things. So the logic system doesn't make sense for them, right? They don't see themselves as an addict. There are steps that are created so for example, one participant said, you know, I hate going to these programs because all they want to do is offer counseling and sitting in a group and talking with people over and over and over. And it's just not helpful anymore. And it just keeps dredging up old wounds that are not good for my recovery. So what happens is, what I found from the individuals that I interviewed is that they begin to remain in the programs, but they rework them. So that they're creating their own recovery despite the programs. And so one of the things that they do is they co-use as a way to manage recovery. And so when programs don't give them enough methadone, for example, then they begin to do bumps of heroin at night. And this is to help them sleep. Because sleep is really important. They want to be able to get up in the morning. They want to be able to go to work. They want to be able to get to the methadone clinic in the next morning. So they're co-using heroin with methadone or Suboxone because they're not adequately able to address their withdrawal. They're also purchasing methadone and Suboxone on the street. It's not super convenient, but it can be a lot more convenient than having to, you know, travel across 2-3 buses across the city. It's always available. You know, I think someone had said, you know, I could easily pick up methadone on this one street for like $10. And so, you know, it's something that people can do and can access. And, you know, no one's going to disrespect you. No one is going to make you stand in a bunch of lines. You don't have to jump on a bunch of buses, which costs money. So for a lot of people, even accessing methadone on the street is an option. One person described it as your morning coffee. So, you know, you wake up, you're withdrawing, knowing that you have methadone in the refrigerator, for example, or that you have extra Suboxone laying around, doesn't just get your sick off in the morning so that you can go on with your day. But it's also the comfort of knowing that it's there, right? Like imagine going to bed at night and you wake up and you're like, oh no, I have no coffee here, right? What am I going to do? I have to figure out how to get that, right? So it takes out that worry, which helps individuals to sleep better, right? It takes away some of that stress. So having street purchase methadone around is important as well for some people. Also, there's a community developing of individuals to help each other, right? So giving each other zips, which are bits of heroin, just to kind of, again, sort of stave off withdrawal long enough until one can safely get either get to the program or get heroin that they need from someone that they trust. It's a way to keep people safe, right? So that they don't, you know, whether they get really sick or whether they get really desperate and they go to a dealer they don't normally trust. We have a big issue with fentanyl being cut into heroin in Chicago. And so that's a huge concern for people. So going to people that you trust to get zips to get you through the day is important. So also participants are working around programmatic rules to wean off quicker because they see that being on methadone or Suboxone is trading in one addiction for another. And so they see the contradiction of, wait a second, I'm in treatment, but yet I'm addicted to something else that you're putting me on, right? And so a lot of them know people who are in methadone programs for years and years and years, and they see that as never ending. They see it as a lifelong drug. And if their idea is to be abstinent at some point, then they want to control that. And so some people have effectively weaned off of methadone in a matter of a couple weeks, and they can do it without the hassle of the program. So how do we apply, and one other thing I wanted to add is that, and this is the important piece of why we need a critical framework, right? Several individuals had indicated when they're telling me all these barriers and they're explaining all these issues, somebody said, one person specifically said, I guess it just didn't work for me because I didn't want it bad enough. So what happens is programs are set up with a logic system of individuality, of blaming the self when things don't go wrong. So even though they see the barriers, the program itself is an untouchable black box. And they sort of figure, well, if they assume the program is set up correctly, and if it's not working, or if they don't get off heroin, it's not because the program's not working, it's because they're not working the program correctly. They didn't want it bad enough. And in another project that I'm in, I just interviewed this person 2 days ago, and he said he was in a recovery home and they kicked him out. And I said, why did they kick you out? And he said, well, they said that I wasn't serious about it. And I said, oh, okay. And he said, I don't think I'll ever call them back or go back there again. He goes, because I guess I'm just not that serious. And so what happens is, it's not even just that there's a problem in that immediate moment, right? That person lost that support. But what happens is they internalize that logic that they did something wrong. They need to figure out how to fix that. And so it shapes where they go get help, if they get help the next time, right? So it's sort of this building upon and perpetuating kind of internalization of this logic system that is not effective for getting people that care that they need. So when we apply a critical framework, and so this is when I'm thinking about doing qualitative research in a program evaluation kind of setting, we have to first scrutinize the ideologies of helping, right, and seeing humanity. And so what does that mean? And so I love the work of Smith because it's one of the first books that I read that helped me to deconstruct the research that we do. Because oftentimes as a researcher, you think, oh, I'm just studying what's there, right? Like there's really no bias. I'm just gonna study what already exists. But oftentimes in public health, because we have such a commitment to doing the right thing and helping people, that we forget that part of helping people is also deconstructing what we think that is, right? And so we have to look at the history of the field that we're in and how it was developed and how has it harmed people in the past. And through its logic system, through its practice, through the research that it does, right? We have to consider the way that we construct health logic, knowledge, and various practices. Why do we do what we do? Why do we help people the way that we help them? And how has that shifted over time and what has impacted that shift, right? So seeing humanity is not enough, right? Really seeing humanity is an act, a process, and a belief system that emerges uniquely within a particular space and should not be separated from its historical significance. We have to move beyond, well, I meant well, or it's, hearts and minds are in the right place. I hear this a lot where people say, well, we intend to do the right thing, or, we're doing better than what they had before. But is that enough? Is that enough for the kinds of programs we want to develop if we really want to help people? We have to investigate the language that we use also. And so one example is, I notice sometimes that a lot of organizations will adopt language that gives the appearance that they're progressive, right? So especially like a term like harm reduction. I see this a lot in very conservative organizations that'll say, oh, we adopt a harm reduction perspective. But they barely define that, much less explain how they use that. If anything, in this one particular organization, they'll say harm reduction, and harm reduction is for them is to help people to make decisions that don't harm themselves more. But that harm reduction is never thrown back on them. What are we doing as an organization that could potentially harm people or that can deepen the harm that is already there, right? It's always about the individual again. So investigating the language that we use and what that language does. And also interrogating the methods and methodologies that may reinscribe power differentials, right? And so again, in program evaluation, again, I love that the work that I do is applicable, but like with any institution or organization that you work with, you're working within the boundaries of the system, right? Either time constraints, money constraints, who can we really invite, or let's just invite the people that can easily get there. I remember I was at, it was a meeting about, prison reform, and it was open to the public. And we often think that if we just invite people, then we've done our job. But just inviting people, just throwing out the welcome mat is not enough. We need to actively consider who is not at this table, how do we get them here, and how do we give them the space to feel really included? To have a community-driven kind of programming is important, and that's on us to do, because people have had so many negative experiences in navigating healthcare systems, especially those most marginalized, that they internalize that they're doing something wrong, that they're not, that it must be on them. Everyone else is fine, but there's something wrong with me. And so it is our job to figure out how to reach out to those individuals. And we also have to think about, as Foucault talks about, interlocking systems of power, because again, those most marginalized are forced to navigate all these different systems, and they're powerful in and of themselves, but they're not just the sum of their parts. Taken together, they become a very powerful way that people see themselves. They see their worthiness through. And so it is our job to break those systems down just a bit and to invite the community to come in and help us restructure those. As Smith says that, thinking about colonialism and healthcare, that oftentimes these programs rely on the subhumanness of people, right? We expect them to listen to us. We expect them to do what we want them to do. We expect them to walk this way and take their medication and do this and do that. We have to shift that if our goal really is to help individuals, right? We want services that they find meaningful, that work for them. So we have to interrogate the process, right? Again, I really strongly recommend this book. It's a little dated now, but I just think it's so important. We have to investigate the categories of Western thought. How do we know what we know? How we've been studying what we've been studying, and can we do it differently? We should do it differently. Also, thinking about how our work fragments the self. And this is the point that I think is important about the qualitative research that I did. That quote that I told you, that I showed you earlier, where the person listed all these barriers of why he was no longer able to stay in the methadone program. But then he just sort of said, well, I guess I just didn't want it bad enough. What happens is the logic systems that we have that don't work for people end up fragmenting them in a way that they feed us the information we need, that we don't have to indict ourselves. We don't have to indict our programs. And so we need to see through that. We need a critical eye in how we do research so that we can uncover some of this. We have to address complex power relations. We have to look at the way our logic systems, work together and shape our understanding within each of them, as well as how we expand the agents that we have. We have so many people who work within the system that are doing different, different sort of policing kind of jobs within these organizations. And so it's overwhelming for people. So addressing those at each point. And so why qualitative research? Well, Grasswick and Webb talk about the importance that those who are most marginalized in a system, they really have a form of privilege, right? They're not just this small group of people we don't need to consider. And again, kind of bringing it back to transgender healthcare, we often think, well, there's such a small population. If we're going to do healthcare, we're going to have this money to do this project. We really should focus on the larger group. Well, let's take gender out of it. Let's just take the most the individuals who have the toughest time getting the healthcare that they need, right? There's this intersection. There's race, there's gender, there's class, there's geography, there's economics. The people who are the most marginalized in all these intersections of social location can offer us so much in understanding how to deliver better healthcare, better social services to all people. And so when people are in complete disequilibrium, then they have an insight into the knowledge that we need to improve our programs, right? Not to mention, the more people that we invite, then we get a clearer picture about the reality of what we are, which is that we are fluid, we are intersecting, and we are constantly shifting trajectories. We are not one thing over time. So again, what we need is a critical shift. We need qualitative research because it provides a window into an experience, into an understanding that we don't have because of our own privilege. It also allows us to sort of reflect on ourselves, right? When we are careful in how we do research, we involve as many people as we can then begin to ask questions to see how they see us so that we can improve our systems. But more importantly, and this is where this key part comes in that I don't think gets addressed very often within program evaluation is, so this is the bean in Chicago. And the reason why this is such a cool sociological structure, in my opinion, is because it doesn't matter where you stand, you're going to, or wherever you stand, you're going to get a different image. Not just an image of the system behind you, but of each person's placement within it. And so you can walk all around this bean and you are going to get something fascinating and something different and unique. And that's what research should do. It should involve people's voices, but it should have a critical mind to look beyond the voices. How do we do a better job at research to ensure we get people's input that's needed to improve these systems that we have? So as we move forward, I'm calling for more of a critical framework at each step, and we need the time and the ability to do that. If we really want our programs to be applicable, if we really want our programs to be sustainable, then we have to adopt a more critical framework in how we collect our data. And so, again, spending some more time on qualitative, inviting the right people, or all people, to come and provide their information, but also to critically analyze what they tell us, because it is developed within the structure that exists, the logic systems that exist. And so if we're going to transform and pivot some of the processes that we do, we have to understand that it is important to understand these different positions, because it gives us a new way of looking at things. It gives us new ideas. And when it is derived from and centered on the community, we have a better job of actually meeting the needs of those that we say we are here to help. So thank you.
Okay, Jodie, we've a question for you. How did you identify, approach, consent, and then facilitate the involvement of program users in the evaluation you did?
How did I get the consent?
How did you identify, approach them, get consent, and then facilitate their involvement?
So for this particular project that I was referring to here, there's a few things. Because we were set up in a needle exchange, these programs have been there for 15 years. And so many people in the community, they're aware of the safety of this program, and they can get free supplies that they need. They can get a doctor's appointment. Again, they're very small facilities. They can walk in and get a cup of coffee. They can get food. So many people by word of mouth know about this program. But for those who don't, we did have outreach workers, individuals who are from that community, who walk around the community and go to where people congregate and just ask if people needed help. So not only would we connect them to treatment, but they were offered $50 to do the 2 to 3 hour interview and do a urinalysis drop. And then, of course, transportation, we give them free bus cards. So that's how they were identified. Consent was an extensive process of reading through the consent materials that were approved by the various organizations that we were a part of. The best part about this, and obviously this is ethical, but at any point they can drop out of the interview and we would still give them the money and we would still connect them to treatment. So if, one particular person, was not feeling well. And that's the other thing too, is we would go through to make sure that they were not going to withdraw during that time. And so we were very supportive of that. If they felt that they might be sick, we, say, well, if you need to go and come back, that would be fine. But we would let them continue if they needed to. But if they dropped out, we would say, listen, we still want to connect you to treatment. So we'll drive you where you need to go. We'll get you a doctor's appointment, whatever was needed. So that was kind of that process.
Okay. Well, can I ask you something about that you started off with? You said you were in academia, then you moved out of academia. From working out of academia for the last 18 plus months, which is more rewarding?
I have to say what's more rewarding. I love interviewing people. I love qualitative research, and but I also love teaching, because I feel that, all that work that you do goes back to the students. So in academia, the students were the most important thing, only because I learned so much from them, and because what I learned, I had an audience, I had a soundboard, I had people to talk, to do that. I didn't really necessarily care for the other part of academia. Like I didn't care for all the meetings. I didn't care necessarily for all the conferences because I wasn't sure what we were doing as experts. I wasn't sure where we were going with some of the work that we did. So in that sense, you know, I miss the students, but I love what I'm doing now because I get to work with other professionals who are nurses and doctors and social service, you know, staff members. And so they have so much information and so much knowledge and so much experience, and they help shape how I ask questions and what's important to talk about. And so to me, that's like re-energizing me every time I approach a project. So yeah, I think that's, you know, I think what I love about both of them is similar things, being around people that have their finger on the pulse.
And how do you legitimize your work outside of academia then?
How do I legitimize my work outside of academia? Unfortunately, even in program evaluation, you know, publications are one way of judging you, and also, you know, whether you get funding. And what's really challenging, especially as I said, my focus is on transgender healthcare. What is really frustrating is that you know, people don't see a real value maybe in funding a lot of healthcare related research around trans care. I find it to be incredibly important. And so we need to sort of shift that thinking a bit. Yeah, so what was your question?
True sociologists lose the question to give the answer. If you take what you say, then how do we then actually think about the being human, the seeing human, if half the humanity, or a third, or an eighth, or a quarter is just not seeing?
So the way that I deal with that, so like one project I'm working with right now is, you know, we have, it's a community health worker project. And so I'm not sure if you have those here, but community health workers are individuals who come from the community in which some of these issues are seen. And so they're hired by these health systems, and they are really the bridge between formalized healthcare and what's happening on the street, especially for those who are without housing, for example, or those without healthcare. And so this particular project gives me the ability to work with community health workers and organizations who employ community health workers. And so, you know, I see them fight against this system of, okay, we understand your voice is important, we have you here, but we don't really have the time to do all this stuff. And so I make a point. So for example, when I had to develop an interview schedule, I make a point to send it, you know, I co-create it with these individuals, with these people who know more than I do about this topic. And then I write it up, and then we sit and we talk about it, and we go line by line, and they'll give me input like, well, you should probably probe in this area because, you know, this is going on, or you should probably ask the question this way. And we keep going back and forth because I'm not going to get great data if it doesn't have any meaning to the people that it impacts the most. And so that's where I think we need more time in doing research to make it meaningful, because if we're on a time crunch, then we don't have the ability to do that. And to me, that's who you're serving, right? So I just think it should be community driven. And they also give me great ideas about books that I should read. And, you know, they've got great ideas about theories to drive their work. So yeah, I'm of the mindset that, you know, we're all experts in our own right and just in different ways. And so how can we together build something? Because the more that they feel that they're a part of the building of it, the more effective it is going to be for them.
And I have a question here for you from Pamela Hussey saying, Jodie, great session. Do you think the digitalization offers us an opportunity to research and support humanity who are marginalized, addressing our interlocking systems of power?
Well, I mean, not if people don't have access to that technology, right? I mean, it can. You know, and that's one of the questions we actually ask people 3 months after they do the telehealth is, you know, what did you think of that? And now here's the thing. Most of the individuals that I work with don't have computers. They don't have the internet at home. And so they would not be able to do this on their own. This was a space that they could do this. But the technology was useful for many of them because it meant that they didn't have to, you know, get on 3 buses. They didn't have to spend all this money to get to a doctor's office. They didn't, you know, I know so many people that I've interviewed that have never really had a negative experience with the healthcare system or with navigating staff, but yet they've heard stories, and so they avoid it, or, they had that one bad experience years ago, and it's enough, and it was painful enough to never go back. So technology can really be useful, but it has to be available. It has to be accessible. I had one particular person say to me, I'm here to change my life, and people treat me like they just don't have time for me, like I'm wasting their time. That somehow they're giving me their own money and their own services rather than the government or the program services. So yeah, I think it's also about like retraining faculty on how to make things more accessible for people. That was a good question.
Don't be telling that. Okay, is there anybody else who have a question? Can you get it into us, please? Otherwise, I'm going to say thank you very much, Jodie.
Thank you. Thank you.